So I want to discuss lenvatinib plus or minus pembrolizumab in biliary tract cancer. There are we have discussed this already. So HER2 amplification. We have many medications: pertuzumab, trastuzumab, zanidatamab, as Dr. Pont just discussed, trastuzumab, tucatinib, and also in HER2, trastuzumab, deruxtecan, and then BRAF V600E mutation, dabrafenib, tremelimumab, we can easily prescribe because it is in the NCCN guideline now. For FGFR2 fusion and rearrangement, we have pemigatinib, furibatinib, and also infigratinib. IDH1 mutation, we have ivosidenib. But what about other patients having no actionable mutations? So there was chemotherapy. FOLFOX was tested. This is the only FDA-approved chemotherapy, and the response rate in the second-line setting was 5%, and median progression-free survival was only 4 months. There are other options: FOLFIRI or 5-FU plus liposomal irinotecan, geminobraxane. So there was a small clinical trial called the LEAP-5 trial, and lenvatinib plus pembrolizumab for BTC. And the response rate was about 25%, stable disease 53%, PFS was 4.9 months, and survival was 11 months. But unfortunately, it was in the NCCN guideline, but this year it was taken off. And we don't have a lot of good options in this setting. And it is quite unfortunate. This is what my patient actually mentioned. Oh, Dr. Lee, it is really sad that other patients are not getting this medication that I'm taking right now. So we treated about 31 patients at MD Anderson, and we have, this is the data from 22 patients. Lenvatinib is an anti-VEGF and anti-FGFR. So out of 22 patients that we analyzed, 18 patients were with intrahepatic cholangiocarcinoma, 1 perihilar, and 2 gallbladder cancer. And the female 17 and males 7 patients, and age 61. Patients received, most patients received both lenvatinib and pembrolizumab. 2 patients received lenvatinib only. 5 patients received lenvatinib in the second-line setting, and the rest in the third or plus lines, and 1 patient seventh line. Based on the LEAP-5 trial, the maximum dose of Lenvima, which was initially in the NCCN guideline, was 20 milligrams, but it is impossible to handle. I treated 1 patient with 20, and then she took it for 2 months, and it was de-escalated to 16 milligrams. Another patient between 10 and 16 milligrams dose adjustment, but almost all the patients took 4 milligrams daily, or 4, 8 alternating, or 8 milligrams daily. This is our data. Median progression-free survival was 5.7 months, and 1 patient has been receiving this medication over 32 months in the 4th-line setting. And 1 patient, 23 months, are still going on, and another patient, 32 months. And only 5 patients received this regimen in the second-line setting, and other patients received 3+ lines. And as we all know, lenvatinib is not an easy medication. So when patients receive this medication in the 4th+ lines, patients didn't handle this medication very well. And 4 patients with the IDH1 mutation received ivosidenib without response before receiving lenvatinib and pembrolizumab. This is our data. So out of 20 patients having good clinical outcomes data, we had 30% response rate, and a stable disease, 13 patients, and there was only 1 patient having progression. And the most common patients who received these medications were with T53 mutations, IDH1 mutation, 7 patients, added 1A mutations, 8 patients, And while the number of patients was not really large, patients who had T53 mutation has no response. They are, as you see here on the left side, there are T53 mutation, the blue color. They are all on the right side. But patients having ARID1A mutation or IDH mutation were quite hypervascular, and they had a better response to lenvatinib plus pembrolizumab. And then the green color, there were some patients having KRAS mutation, and this patient is the patient who have been on the medication over 32 months. The tumor had about like a 30% tumor shrinkage, but it got a prolonged response. This is one of my patients who has IDH mutation. As you see, so we did a Hounsfield unit. We measure the hypervascularity on CT scans, so before and after response. And then this graph, the x-axis is a baseline Hounsfield unit. As you see here, given a small number of patients, we don't have a good statistical conclusion was drawn here. But hypervascular tumors at baseline had a better response to lenvatinib. They are the orange circle there. A few hypervascular tumors, while having decreased vascularity after the exposure to lenvatinib, actually increase in size. They are the green color right there. And we also did messenger RNA analysis. And for example, one patient, I pointed that out with a blue arrow there. Patient who had a very elevated expression of genes related to VEGF or VEGF receptor had a very good response. One patient whose tumor was quite hypervascular, having FGFR3 amplification, had a tumor reduction by more than 60% to lenvatinib. And except for two patients, tumor periphery brightness decreased after exposure to lenvatinib, and most tumor, and also this x-axis in the graph, it is a Hounsfield unit decrease, and most tumors that became more hypovascular after exposure to lenvatinib also decrease in size. So summary is once again, this is a small data, and then the selection is quite biased. So most patients are my patients. So I review the scans, the CT or MRIs. If a patients are hypervascular, then I do lenvatinib. If the patients are not having tumors, having hypervascular tumors, actually most cases in cholangiocarcinoma, then we don't select and provide lenvatinib. So these selected patients, response rate was 30%. And this is actually better than most other chemotherapy medication in the second line setting or fourth line setting. And T53 mutation was related to poor response to lenvatinib. But IDH1 mutation and ARID1A mutation were related to better response rate because most tumors are quite hypervascular. And tumors that are hypervascular at baseline are likely to respond to lenvatinib quite well. And although based on the LEAP-5 trial, the maximum dose of lenvatinib was 20, but 20 is also, once again, impossible to handle. So consider starting lenvatinib 4 milligrams and then increase or decrease in dose adjustment. And then we want to consider lenvatinib before we get too late, because lenvima is not really easily tolerated when we give it in the 5th line or 7th line. Nowadays, every single patient getting NGS is also getting messenger RNA. So now messenger RNA analysis is not a part of the actionable plan, right? So we have, but if a patient has expressed elevated expression of genes related to VEGF and also FGFR, then the patient tend to respond to better to lenvatinib. Thank you.